Okay, so welcome back to the second part of the conference today. Welcome to those online that have joined us as well. So I'm delighted to introduce Mr. Sreekantam, Consultant Ophthalmologist at Samwell and West Birmingham Hospitals Trust.
Good afternoon. Thank you very much for inviting me, and it's a privilege for me to be here. It's the first time I'm presenting in BEHÇET'S, UK. And I didn't realize they were giving me a session immediately after lunch, so that itself is a big challenge. Okay. Okay. So I thought I will go through my journey first, because I think that will give a context to the challenges that I faced in BEHÇET'S and how I managed, along with my team in the Birmingham Center. I was trained in West Midlands, and as part of training, in the final year, we get to choose a subspecialty, and I chose inflammatory eye diseases, and was under Professor Murray in Birmingham. And after my training, I was in Manchester for 6 months and did my fellowship under Professor Nicholas Jones. Now, while I was a fellow here in Birmingham, I also happened to have a session in BEHÇET'S Center, which was very useful for me because it was the first time I worked in a multidisciplinary team, and then it was also an opportunity to understand BEHÇET'S better and also understand the patient's journey through from the diagnosis, treatment, and monitoring. I started as a substantive consultant in the Eye Center in Birmingham in 2018, and I've been part of the team in the Birmingham BEHÇET'S Center since then. So the challenges that I have encountered during this period related to the diagnosis, treatment, and monitoring, and that is what I'm going to be talking about this afternoon. And I will also be presenting cases to demonstrate the challenges, but I think that will be more it's easy to understand the challenges when I present it as a case. So we all know the diagnosis of BEHÇET'S is a clinical diagnosis, and the ocular features, the eye features, again, is a clinical. It's based on pattern recognition, and then we correlate these features with the systemic features of oral ulceration, the skin changes. So since I started, I looked at the data, looked at our cohort of patients to see what were the various manifestations. And around 35% of patients that have been seen in our center have ocular manifestations, and predominantly it is uveitis, this is the inflammation of the middle layer of the eye. And the front of the eye can be involved, or the back of the eye. It's the inflammation at the posterior aspect of the eye, which is sight-threatening, and when it happens, it is quite devastating for the patients. But we also found in less than 5% of patients that they can present with non-uveitic, so it can be an inflammation of the optic nerve, it can be inflammation of the white portion of the eye called the sclera, and it's 5%. Now, these do not happen to be, it's not one of the defined features in any of the criteria, that is the ICBD criteria or the ISG criteria, but there are reports from various parts of the world that have reported optic neuritis and scleritis. So it's something that I'm keen to monitor. So the first case is a 27-year-old male who was referred from Devon. He woke up one morning with the loss of vision in his right eye. Unfortunately, it was irreversible loss. And he was referred to the eye clinic. They felt it was optic neuritis and referred him to the local neurologist, who arranged an MRI scan, which revealed certain changes in the part of the brain called corpus callosum, which confirmed it was an inflammatory change, but then the question was, is this a demyelinating disease? And there was no treatment at the time. He was just being monitored. Fortunately, in 2019, he had another attack, but this time it was in the left eye, which spared his central vision. Around the same time, he happened to be under the dermatologist for recurrent nodules on his chin, which was diagnosed as erythemanodism. And he gave a history of recurrent oral and genital ulceration. And the dermatologist then highlighted the fact that could this be BEHÇET'S, and that's how he was referred to the center for diagnosis, confirming the diagnosis, and also to start him on proper treatment to prevent any further loss of vision. We saw him in the clinic. We confirmed in the history that he has a recurrent oral aphthous ulceration, which is something we see in BEHÇET'S. He showed us the pictures of the skin changes, which is consistent with the erythema nodosum. We have a neurologist who was very helpful, and he reviewed the scans, and he confirmed there were some inflammatory changes in the brain, but these were not typical of what is seen in multiple sclerosis. And if I, as an ophthalmologist interested in inflammatory eye disease, if I find somebody with changes in corpus callosum, my immediate question will be hearing loss. And he did say that since the start of the eye symptoms, his parents have mentioned that he was speaking in a louder tone than normal, and that was something which concerned me. So now, any ophthalmology talk is incomplete without pictures, so I had to put some pictures here. So what you're seeing are the fundus images, the back of the eye. So to your left is the fundus image of the right eye, and to the right is the fundus image of the left eye. Hope it's clear. What you're seeing, the circular disc in the center, is the optic nerve that connects the eye to the brain. And the red lines that you're seeing are the blood vessels which converge at the optic nerve. And some of them actually diverge from the optic nerve. So the vessels that converge at the optic nerve are the vessels that drain blood from the eye into the heart. And the vessels that arise from the optic nerve are the arteries which supplies blood from the heart to the eye. Now, in this patient, in the right eye, I don't know how clear it is, but you could see that the vessels are thinner when compared to the left eye. So this confirms that this patient had a vascular event at some point, and that's responsible. But apart from that, there are no other features of inflammation. We got the notes from the local eye team, and there was nothing to suggest that he had any inflammation in the eye. So all we know is there is some vascular event in the eye that was responsible for the poor vision. So we have this patient here who's lost vision and has got whole loads of symptoms. What is the diagnosis? BEHÇET'S, yes, it is a plausible diagnosis here based on history of recurrent orogenital ulceration in the skin changes. But then the MRI findings were not convincing of neuro-BEHÇET'S. And could this be a demyelinating disease like an MS, multiple sclerosis? But then again, it was an atypical site to have a lesion. Or is it a condition that we call Susac syndrome, which is basically an inflammatory condition which affects the brain? The underlying thing is all these are inflammatory conditions, and we had to do something for this patient to protect his eye and to save his vision. So we recommended the patient to be started on systemic immunosuppression, and we're keeping an open mind here, just in case if the patient has new symptoms, and then we correlate and see what else to add to stop this patient from going blind. And that then takes us to the challenges in treatment. And what we do is if we have a patient with ocular BEHÇET'S, we follow the EULAR recommendations, where the recommendation is to commence systemic immunosuppression alongside the corticosteroids at the same time. And this is to minimize the recurrences, because with each recurrence, there's an increased risk of sight loss. So we want to minimize the recurrences, therefore commence the patient on the systemic immunosuppression. Now, we have conventional agents, and the preferred drugs that I use is azathioprine or mycophenolate. But we also have access through BEHÇET'S clinic. We have easy access to biological agents, mainly the anti-TNF agents. In some patients, we could get different biological agents like anti-IL-6. And we also used to have access to an interferon, which I put it in italics because it's no longer available. So there's no availability of this interferon anywhere in the world. We also now have access to localized treatments. These are steroid implants, which help in controlling the inflammation. I tend to, in BEHÇET'S context, I tend to use this if a patient who's already on maximum immunosuppression and has occasional flare-ups and needs some kind of control over the eye disease, I then offer these implants. So there is an implant called OCULAR, which is a shorter-acting implant used to treat the acute inflammation. And then there is ILUVIEN, which is a longer-acting implant, which is useful in preventing recurrences. And it's not very frequent that I use this in Behçet's patients because Behçet is a systemic condition, so it's important that the patient has a good control, so it's better to have a systemic immunosuppression. But occasionally, there were 1 or 2 patients where I had to use these implants to have better control and stop visual loss. So the second case, it's a 21-year-old South Asian male from Birmingham who presented to eye casualty with the bilateral blurred vision. And he also has a history of recurrent oral ulcers and was under care of a local dental hospital. And the oral medicine specialist, they did query possibility of Behçet's in him, but at the time, there were no other features apart from oral ulcers and an acneiform rash, which he sees a local dermatologist privately. Again, here, probably what you will see here is these white beaded chains, which is basically inflammatory deposits in the jelly inside the eye called the vitreous. This is non-specific. It is seen in Behçet's, but it is also seen in various other conditions. So in this situation, what I tend to do is arrange a dye test, which is called a fluorescein angiogram, where we inject a dye into the veins, and as it circulates in the eye, we take pictures. So in a healthy eye, what we expect is the dye to just stay in the blood vessels, but in an inflamed eye, the dye starts to leak into the surrounding tissue, as you can see here. And what you're seeing here is the dye flowing through the blood vessels, but it's also leaking into the surrounding retina. And the pattern of this leak is something which is very, very typical of Behçet's. So we have a young patient here who has recurrent oral ulcers, who's got acneiform rash, bilateral eye disease, and features are consistent with Behçet's. So it's high probability that this patient has got Behçet's. So we start him on oral steroids, and then I send him for a test to screen for latent infections to make sure that he's safe to commence a biological agent. And when the blood results start to come down, it's kind of, my heart sank when I saw this result, which is quantiferon, which is one of the tests that we do to check if a patient has any contact with the tuberculosis bug. This is important because in presence of a positive test, we cannot, or it is not advisable to give an anti-TNF because of risk of tuberculosis activating and causing major problems. So this positive test, what it means is this patient needs to have treatment for latent tuberculosis first, and then he can go on to the biological agent safely. Based on my previous experience in different conditions, I knew where this was going to go. So I made an urgent referral to the chest physicians to start this patient on tuberculosis treatment. And when the patient goes on to the tuberculosis treatment, the effect of the steroid drops, so the patient needs to go up on the steroid dose, and that's going to cause major problems for the patients who are on steroids. So although this patient was on steroids, he had good relief from his symptoms. The ulcers were better, his vision was getting better, but the side effects of the steroids were becoming unbearable. Mood fluctuations, putting on weight, becoming more chubby. These were all affecting his self-confidence. So I had to increase the dose of steroid because of the anti-tuberculosis treatment, but I also offered to him the option of injecting a steroid implant into the eye, which can avoid the systemic side effects. So the patient opted to go for an injection. So I injected the left eye first. But post-injection, he developed one of the side effects of the steroid, which is the pressures inside the eye going up. So that, if it's left untreated, can lead to a secondary glaucoma, and that itself can cause blindness. So that had to be treated, so which means additional eye drops and additional tablets to control the pressure. So this is a patient who is having to take too many medications to maintain the vision. Ultimately, we managed to get the pressures under control and wean him off the steroids, and after 4 weeks of antituberculous treatment, we started him on anti-TNF treatment on infliximab infusions. But in ideal world, in such a situation, the drug of choice would have been interferons, which unfortunately we do not have the availability of this drug. So in endemic countries, especially the Middle East, where TB is quite prevalent, they have used interferons, and there's very good data to show the interferons actually controls the disease quickly without the need for steroids. And majority of patients do go into good remission quickly, but there are some side effects which can be bothering, especially it can affect the mood of the patient. They can go into depression, they can have problems with liver enzymes, there can be problems with the blood counts, and that can lead to opportunistic infections. As I said, the interferons was discontinued in 2020, but then there is another interferon which is available, which is called pegylated interferon alpha, and what it means is that it stays in the blood for a longer period, so there's no reason, there's no need to have these injections taken every day. It can be just given every week. But this is an unlicensed product, and therefore I'm a bit hesitant to actually give it to any of the patients because there's no randomized control trials to say that this is better or works in Behçet's disease. Now, challenges in monitoring. Like any condition, once a treatment is initiated, we monitor for disease activity. We look for any damage that's been done by the disease and how we can minimize the damage. But more importantly, when the patient is on such heavy immunosuppression, they need to have monitoring of their body functions to ensure that they are not they don't have any organ damage. So I'll confine myself to the monitoring the activity, which I do by using an accepted grading, which is called the SUN grading, which stands for Standardized Uveitis Network Grading. But the problem with this grading is it's very subjective, and it can be variable between two examiners. But there is, with new technology, there is a possibility to have an objective assessment, and that is with retinal imaging using optical coherence tomography, which is commonly called OCT. Then we have fundus imaging. We can take good pictures of the eye and then compare. And as I showed you earlier, the dye test, the fluorescein angiogram, which is very crucial, and it's accepted, well-recognized diagnostic test that is useful for monitoring the disease and also deciding on the patient tapering the dosage of the immunosuppression. So coming back to the second case, who was on infliximab. So 6 months after the infliximab was started, there is good control. So the patient is happy. The ulcers are well controlled. There's no skin problem. His vision is better. But doing a fluorescein angiography, it still shows there is still some clinical subclinical inflammation that's happening in this patient. So we then switch him to a different agent to have better control on the ocular inflammation. So we switch him to an adalimumab subcutaneous injection. 1 year later, the inflammation is better, but it's not completely gone. So now we are running out of options. So I add a conventional agent, which is the azathioprine medication that he takes every day. And 2 years down, there is good control on the inflammation, but very, very mild inflammation, mainly in the periphery of the eye, which the patient at this moment, he does not want any change in the treatment because he's happy with the way things are, and he wants to continue on the treatment as it is. Yeah. So fluorescein angiogram is a very important piece of test that helps me in deciding whether a patient needs to change the treatment, whether the patient is in good control of the condition, or whether if the patient if the patient has been on long-term treatment with good control and wants to come off the treatment, then fluorescein angiogram is very crucial. to decide whether or not to start cutting down the immunosuppression. But the problem is it's an invasive test, and with every injection, there is a risk of anaphylaxis. And it's just not one-off test, it's a multiple test. And we have got patients coming all the way from Devon, and it's practically not possible for patients to just attend the clinic for this test in the eye center. So is there an alternative? There seems to be one. So it's a kit called laser flare photometry, and there's a study from Turkey where they compared the fluorescein angiogram with the flare antechamber flare using this equipment here, and it seems to correlate reasonably well. We have this equipment in the eye center, and I wanted to use it. It's something it is easy to operate, but I need training to understand how to interpret the numbers this machine generates. It's a machine that's not widely used. It's not used in United Kingdom. It's widely used in Europe and in Turkey. And I arranged to attend clinics. And the first time I did that, the COVID set in. And now I plan to go to Turkey in spring or summer next year. But then the Middle East crisis is worrying me now. So finally, this is my last slide. In the next year, we have another equipment called OCULAR, which is interesting. It's a research equipment which looks at the stress in the retina in any condition that affects retina. And we're planning to use this in Behçet's patients, especially to see if patients who have Behçet's but no eye problems, and whether do they really have no eye problem, or are there any markers to suggest that they may have a very subclinical inflammation, which is not apparent when we see them in the clinic, or the patients are not symptomatic. So this is something that we plan to start in the next year. But also, I discussed this with the Deva to see if we can organize a clinical trial to look at the efficiency of pegylated interferons. We need a randomized control trial to see if this is an effective drug and if it's something that we can offer to the patients who may not be suitable for an anti-TNF agent. That's it. Thank you.
Okay, so we're going to move on to Dr. Eslam Al-Abadi, who's a consultant pediatric rheumatologist, and he has a particular interest in autoinflammatory syndromes and Behçet's disease.
Hello, everyone, and thank you for the invitation. I'm a pediatric rheumatologist over at Birmingham Children's Hospital, and very fortunate to be doing the clinics alongside Deva and colleagues. This is what I hope that we're going to cover today. We're just going to look at what are the causes of recurrent mouth ulcers in children, how to manage mouth ulcers in children, the features and diagnosis of Behçet's syndrome in children, and the childhood Behçet's syndrome in the UK, and finally a touch on the genetic mimics. So if we look, sorry, is there a way of making this screen bigger, just to stop me from turning round all the time? No? Oh, there we go. That's a lot better. Yes, now I can actually. Right. So this is a child who's 9, who's had recurrent mouth ulcers and has had a couple of episodes of mouth ulcers in the last 6 months. They tend to last 3 to 7 days. They're quite painful. They're variable in size and severity. And they've used the Bonjela application to soothe their ulcers, and it's been affecting their ability to eat and drink. And if we look at the ulcer, it's round or oval. It's got this yellowish elevated kind of spot, and it's surrounded by a red halo, and it's kind of a punched out ulcer and covered with a white or yellow membrane. And that is a typical aphthous ulcer. That is what a Behçet's ulcer is. If it's not an aphthous ulcer, it's probably not a Behçet's ulcer. So does this child have Behçet's? And for that matter, do they all have Behçet's, all these different children here? We kind of gave a description earlier of the aphthous ulcer, so I'm not going to go through this part again, but just to kind of give you an idea about how common this is. Behçet's is a very rare disease, particularly in childhood, and yet the mouth ulcer, which is the main presenting feature, is such a common feature. 10% of children will usually have mouth ulcers for no reason at all. Goes up to 20% in adolescence, and when they're unwell, they might have more. They're usually obviously painful, so they're quite symptomatic, and they are brought to the attention of the parent or healthcare professionals. These ulcers can be isolated in the sense that there are no other features happening at the same time, and this could be because of infection or because of allergy or because of biting the inside of the tongue, or there's this condition that's called recurrent aphthous stomatitis, which is of an unknown cause. They can also be persistent for a variety of reasons, such as infections, malignancies, or allergies, and so on, and mineral deficiencies. We'll put these up. Right. Mouth ulcers can also be caused as part of associated symptoms. So you might have children who have mouth ulcers but are pale, bruising easily, and have bone pain. They might have malignancies. Those who are experiencing weight loss and gastrointestinal features, and they might have inflammatory bowel disease or celiac disease. Those who might be experiencing recurrent fevers, sore throats, lymph nodes, and they might have something we call an autoinflammatory syndrome. There's a poster at the back here about the magic syndrome, which I actually hate the name of. Mouth and genital ulcers and inflamed cartilage, so your kind of your nose and your ears and the bit of cartilage around your joints become inflamed. I don't think the patients would think that that is magical in any way. Unfortunately, there are situations where we are confronted with where there is a factitious illness being at hand. And there are other multisystemic inflammatory diseases like lupus and other connective tissue disorders. And finally, of course, Behçet's. This is more of a personal practice towards investigating a child who's having recurrent mouth ulcers, looking at their blood counts, minerals and vitamins, inflammation markers, checking if they've got celiac disease, checking if they've got any infections, particularly things like herpes. And then in selected few, we might do additional investigations, which might include other things like genetics. So my first take-home message was that mouth ulcers are common during childhood. The differential is quite wide, but Behçet's disease is rare. So trying to identify which child that presents with a mouth ulcer is ultimately going to have Behçet's disease is quite difficult. So we consider a wide range of differentials at presentation and revisit the diagnosis should new features occur in the future. This young man presented to us with recurrent mouth ulcers for 17 months and has had different treatments, mostly topical applications, and then presented with an episode of mouth and genital ulcers for 2 weeks and saw his GP on a few occasions and went to the pediatric assessment unit eventually, was in a lot of pain and distress, taking a kind of a detailed history from him. He's not sexually active, but does have joint pain, but without swelling. So does he have Behçet's syndrome? And to answer that, we probably need to look at how we can arrive at a diagnosis. What is Behçet's? It's a chronic and relapsing, remitting inflammatory disease. The onset is usually insidious. It affects any type of blood vessel and manifests with predominant recurrent oral ulcers, genital ulcers, skin manifestations, and eye disease, amongst other features. It has a wide range of pathophysiology attached to it, and whether you call it autoimmune or autoinflammatory, that just refers to the part of the immune system that is predominantly at play and causing the inflammation. And depending on which population you're in, childhood onset might be as low as 4% or 26%, or as high as 26%. And there is no diagnostic test that can tell us that this person has a Behçet's disease. There are, however, classification criteria, and these are not used for diagnosis, as many of you would know. These are there to help us conduct research and be able to compare like for like and make sure that the people that we're comparing are actually very similar to each other. And that is the purpose of classification criteria. And there are multiple of them. There's the ISG and the ICBD. And in children, when we look at these criteria, based on what clinicians' expert opinion say is Behçet's disease, the ISG criteria are 85% sensitive and 96% specific. So it's very unlikely that somebody doesn't have Behçet's syndrome has been misclassified as Behçet's syndrome, but it might miss a few. On the other hand, the ICBD has very high sensitivity, so and low specificity. So it gives you an idea that maybe there's a few patients that might slip through that aren't quite strictly by these criteria got Behçet's disease. But if we look at the ISG criteria, for example, they have a very strong emphasis on mouth ulcers. And as far as children are concerned, nobody's going to do a pathogy test on them because it's very painful and distressing to children. And that involves passing a needle and injecting some saline under the skin and seeing how they react afterwards. It's difficult at most times to get a blood sample from a child, let alone do a test that involves injection. So there are efforts to have international pediatrics Behçet's disease criteria, but the sensitivity and specificity of those is not yet validated. These are ongoing. And as you can see here, there is no emphasis, there's no heavier weight towards one symptom compared to another, recognizing that childhood Behçet's might present in a slightly different way with less of the features that you see in adult onset Behçet's disease. So our young man was diagnosed with Behçet's because we've kind of excluded everything else that could have been causing these symptoms. He went on to have some topical treatment, prednisolone and colchicine. 4 months later, he also developed panuveitis and was eventually started on an anti-TNF medication. And many of you might be familiar with this slide. It might be a little bit busy, but basically it's saying that at the milder end of disease, we're relying a lot more on colchicine and topical applications. And as disease severity or response to treatment diminishes, we then are requiring more systemic treatment in the form of azathioprine or anti-TNF medications. Sorry. Oh, it's jumping a lot. I think we can skip this bit here. I just wanted to focus over here on our experience in Behçet's. We've looked retrospectively at our patients and found that within our Behçet's cohort, there is 61 patients who actually recall their first symptom to have started before the age of 16. However, only 26 of those have had fulfilled the ISG criteria at an age less than 16 years old, which kind of takes you that this is a process and symptoms might occur simultaneously. Nonetheless, the quality of life and the recurrence of symptoms has plagued those individuals throughout that time. Still with that data, the age of first presentation or first symptom, 9.5-year-old, 9.5, sorry, and the age of the second symptom was nearly 20. So you can see, in order to make a diagnosis, some patients would have to wait a very, very long time. So second take-home message, the classification criteria are not diagnostic criteria, and the diagnosis remains that of an expert opinion and requires a high index of suspicion. In the UK, there have been attempts to understand the epidemiology of Behçet's disease in children, and this work was led by Claire Payne, one of my colleagues at Liverpool. And basically what it found that there is a slight female predominance and that we can give an incidence to childhood onset Behçet's of 4.2 per million. So it's still quite a rare disease. And the median age of onset of symptoms was 6.3, with the first presentation to a healthcare professional at 10.6 years, and the final diagnosis being made at 11.7. So even then, probably 5 years from first symptom to diagnosis. The symptoms were varied, and this is just to kind of say that there's a lot of people involved in the journey of that child, lots of healthcare professionals, lots of opinions, bouncing from one clinic to the next clinic trying to get a diagnosis. And that's where, hopefully, the centres of excellence will come in and reduce that burden on the patients. So the take-home message I wanted from here is that there's significant delay between onset and diagnosis, and that UK children present differently to other cohorts and UK adults, predominantly with a mucocutaneous disease. And it has, but despite that, it has a high health burden, because 75% of children require immune suppressive drugs, and 25% carry on having uncontrolled disease. Coming to the genetics, this was an interesting study where people looked at data sets and looked at people who were identified to having recurrent after stomatitis. This syndrome is PFAPA, is an autoinflammatory disease where you got periodic fevers, aphthous ulcers, glands in your neck, and pharyngitis, which is sore throat, like me today, and Behçet's disease, and found very similar genes between those populations, which prompted the authors to think of it as being a continuum, one disease spectrum, and it's a journey from one end to the other. Without going into all the details of this case presentation, this is a family of 2 daughters and mum, who all had some features of Behçet's disease that you will all recognize, which prompted us to think that surely this is not just coincidence, and therefore requested some genetic investigations. And the child, well, all the family had this A20 haploinsufficiency, which is a deficiency in a particular protein coded for by a particular gene. And this was a study from different families that are unrelated, of different ethnicities, showing that this gene will cause disease in multiple generations, and that the features are actually, although similar to Behçet's, not identical to make a final diagnosis. Interestingly, their treatment was very varied. Some people required absolutely no treatment at all, and some people just did not respond to whatever you gave them. So very variable in its nature. This is a paper from our colleagues in London, who again looked at those patients who had some features of Behçet's but not completely fulfilled the criteria, or had a strong family history of Behçet's disease, or were too young when they started with their symptoms. And they found 11 different cases in their cohort with known other genetic diagnoses that are known to cause inflammatory disease that were possibly mislabeled as Behçet's disease and led to possibly different treatments eventually. And that's probably the third take-home message, is that we would really like to screen those who are young, those who have strong family history, and those who have some atypical features of Behçet's disease. There has been a follow-on trial from that, study from that isn't published yet, but basically it's heading in the same direction and suggesting that maybe everyone should be tested for these inflammatory conditions, inflammatory genetic conditions. So I think these are the final take-home messages, just to summarize from the previous slides. I think I'm just on time. Brilliant. Okay. Right.
So again, if you've got any questions, the medical panel later, please do put them down. So now he's almost on the stage. Professor Graham Wallace has arrived. So he is senior lecturer at the University of Birmingham. He has written countless research papers and reviews and has a specialist interest in Behçet's disease as well. So we're very happy to have him here today.
Thank you very much. So first and foremost, for those that don't know me, as I said, I'm not a clinician. We're called discovery scientists now, but I'm not quite sure what we've discovered. And the other thing is that I'm fairly certain I could be replaced by a machine fairly soon, so we'll see how that goes. How do we move on? Oh, that one. There we go. Right, so I'm going to give you a research update. This isn't from all our work. This is from colleagues across the country, and in fact, across the world. So I just want to put this slide up, and obviously we can do lots of these and draw diagrams and so forth, but a couple of things I'm going to talk about is the Th17 differentiation down here in the middle, and its relationship to these things called SCFAs, short-chain fatty acids, in particularly something such as butyrate. And above that, you're looking at the gut dysbiosis. So this is a lot of the metabolomic microbiome studies that we've done as far as that's concerned. And these sorts of aspects that people are looking at now, they're trying to identify pathways that they can perhaps intervene and see what happens. Now, as I say, particularly I'll talk about the butyrate situation. So these are from a recent review that we did, and these are all the microbiome studies that have been done, certainly at the time of writing. And what we have here, when we've got reduced bacteria, the ones that are in bold, all tend to be from the same sort of species, the Clostridia species. And this was identified by Giacomo Emi in a study that he did, and this was related to a reduction in this molecule called butyrate. And what we hope is that genetics can also help us to understand what's happening with the microbiomes in these situations. So down here, we've got the classic interaction of activation of an immune response. You've got a dendritic cell there. It recognizes something from, say, a bacteria, like lipopolysaccharide. That will actually activate a population of cells that are in the gut. And IL-23 is a molecule as well that is driving this process. IL-23 is upstream of the Th17. I know it sounds a bit alphabet soup, but these molecules, the ones that I've circled there for the moment, have been identified already in Behçet's as being with mutations in those being associated with disease. So this cell called the ILC will actually produce another cytokine called IL-22, and that will activate a molecule within the small intestine epithelial cells called FUT2, which is a fucosyl transferase. And this actually, what it does is it cleaves off these short-chain fatty acids from the bacteria. That's the yellow circles up there. And you can see there the SCAFAs plus other metabolites are present there. And they can be released from the gut into the systemic, into the blood and so forth, and they will actually help regulatory cells. So the Th17s would be regarded in most cases as an effector cell and a cell that's possibly causing trouble. If you've got too many of them, it's not controlled. The short-chain fatty acids are thought to be regulatory and actually help to bring that down. So the dietary sources of a lot of these, it's all linked to dietary fiber, so the usual good guys, the whole grains, fruits and vegetables and so forth. Dietary fiber, all these long names underneath this. And then the gut microbes. And these are all, you hear the Yakult advert in the good microbiome, then that's basically what these cells are doing. They're breaking down things that we can't actually break down normally. So we don't have a good mechanism for breaking down fiber, whereas bugs are extremely good at it. And they'll produce, as say, these short-chain fatty acids, and these can be released into the blood to give the systemic effects that we're looking at. So what these short-chain fatty acids can do, it can release things like insulin from the pancreas. You can have fatty acid flux from adipocytes, and that can be a good thing. It can affect the appetite centers in the brain, but it can also influence inflammation. So again, down here, you've got the release of the short-chain fatty acids into the hepatic portal vein, into the liver, and then into the broader systemic pool. And it's got a series of effects, things like acetate, propionate, butyrate are the classic ones that we're looking at. And there's a lot of work going into looking at these short-chain fatty acids and what they can actually do. And more to the point, can we actually influence the production of these particular molecules? Now, one of the ways in which we can do this, and these are perhaps things that you've heard about as well, so probiotics and prebiotics. DMARDs are the drugs that you've heard about already from my clinical colleagues. But probiotics, when you actually give a molecule into the body that it already needs. A prebiotic is when you give it a foodstuff that will actually lead to the production of the similar probiotic. So in this case, a probiotic would say be butyrate if you were giving that in. A prebiotic would be a diet that would actually increase the production of butyrate. There's obviously the biological drugs that colleagues have talked about as well, and antibiotics, and something that you may have heard about for other conditions, particularly for things like C. difficile, is a fecal transplant, which sounds terribly yucky, but the idea is that you actually seed somebody's colon with a microbiome that is much healthier, and that will help to get rid of particular conditions. Clostridium difficile is a problem in many individuals, particularly if they've been on antibiotics. C. difficile is normally kept under control quite happily by the other bugs in the gut, but when you get rid of a lot of those ones, then C. difficile will actually grow and cause problems. So certainly the fecal transplants have been really quite effective at dealing with this, and people are now looking at the possibility of doing this in other conditions such as IBD. Dave and myself have talked to one of our colleagues at Birmingham, who's actually running the IBD trial. Is there a case for doing this perhaps in some patients with Behçet's disease, particularly if they've got GI Behçet's? But so far, that's one of the conversations that hasn't got out of the pub, but we're working on it. Big problem is remembering what we said the next day. But colleagues in Italy, Giacomo Emi has led on this, has set up the MAMBA trial. And what he did with this was actually to do two things. One, to give both the prebiotic and the probiotic treatments. So in one, they supplemented butyrate to the patients. And the other one, they gave them a diet that is likely to generate high levels of butyrate. And this is just a list of the findings that they had. They found a significant effect in the reduction of the redox status. Now, that's a terminology. It means you're not producing oxidative molecules that can cause tissue damage. So they were damped down as far as that was concerned, and the patients with these conditions. And some of these are things like ROS, the reactive oxygen species, and lipid peroxidation were also significantly decreased following the butyrate supplementation, either the endogenous, in other words, the butyrate itself, or whether you gave it in the diet. And there was a significant improvement in antioxidant capacity. You've probably heard about antioxidants. They combat the reactive oxygen species and so forth. And again, many things that you'll hear advertised on the TV have got antioxidant activity. I'm not sure I believe too many of those, but this is certainly a real aspect, and knocking down those sorts of oxidative species that can cause damage is obviously very useful. The 3-month butyrate-enriched diet didn't affect, actually, the gut microbiome composition, which was potentially a surprise, but it was suggested that actually maybe a longer nutritional intervention might be required. So we can actually see the changes in things like the oxidative species without actually seeing any major changes within the gut microbiome itself. And that's perhaps telling us other aspects that we need to do, that we don't necessarily need massive changes, we just need to feed that microbiome the right diet, for example, and we still don't know what that is. The butyrate diet that they had included things like cold potatoes and chicory, so it's not really going to be high on people's lists particularly, but there's obviously more work to be done on identifying what perhaps slightly more palatable, I mean, even just hot potatoes rather than cold ones, but something slightly more palatable that we're doing, but this is ongoing. And Giacomo and his group are now doing a second study where they're doing a random crossover dietary intervention. So you set them on one pathway and then you cross over to a second one to see what happens. There's 38 patients in this trial. And they found that close dietary control and the regular follow-up displayed benefits in terms of clinical disease manifestations. Although at the moment, when they produced this outline, there was not reaching statistical significance, but there's potentially, leaving it longer, that we will see that. But there were clear benefits as far as this was concerned. The LOV, that's the diet intervention, significantly reduced the daily glucocorticoid dosage that these patients were on, as well as the percentage of patients receiving steroids. And again, as both Sri and Eslam have mentioned, there is this point that you get to a stage with steroids where it's actually causing more problems than doing good. So the more you can actually taper the steroids and potentially take them off this is obviously going to be a major bonus if we can do this. And then evaluation of GI symptoms showed a reduction in the GI score following the nutritional interventions. And in this case, it actually achieved statistical significance in the Mediterranean diet group. So in this case, they're different diets as well, the LOV diet, but they put them on a traditional Mediterranean diet. Giacomo's based in Florence, so they're a bit too far up for that. They still sort of eat pizza and so forth. You know, it's the people in the south that have the good diet, allegedly. So this work, we wait to hear the final data set for this, but the potential with regards to this, even if it's going to be related to things like being able to taper steroids and to reduce the damage producing reactive oxygen species, would suggest that this is got potential. There's one other paper that I'll just share with you. This is N equals 1. It was a female of 49. She had Behçet's disease with anterior uveitis and fairly constant problems with the types of things that you would expect to see. And in this case, they gave a symbiotic supplementation, and that just means some of it's probiotic, some of it's prebiotic. But here's a list of the 7 strains of bacteria that they gave. It was given as a capsule twice a day. And at the time, she was on azathioprine, colchicine, and prednisone. And this is just following over the time. So the top line is basically where she was when she started. And then over the next sort of year or so, 9, 10 months. And you can see that in the middle line there in December, things like the CRP hadn't really changed very much, and neither did the FPS counts. But when you get down to about May, then the CRP is well down, the highly sensitive CRP is down as well, the sedimentation rate on the far left is, again, lots of things have come down. And she had 2 attacks of anterior uveitis in the first 2 months, and then none for the last 7. So actually, it would seem that this symbiotic treatment of these various bugs is actually having an effect on her anterior uveitis, mainly by knocking down markers of inflammation, but there would be other things that we should look at. So the potential for actually having some dietary interventions in something like Behçet's may well be a possibility. Now, I do insist we don't know what that is at the moment. There's a lot of work going into this, and we wait to hear the full results from the second MAMBA study. But this is potentially a relatively more straightforward way of dealing with this disease, especially if you're knocking down things such as steroids and so forth. I just want to mention this as well about, I'll ask you questions on this later, but this is basically about the fact that you've got thrombosis is an issue as far as Behçet's patients are concerned. And looking at this and looking at the vasculature, then our colleagues across in Turkey have been looking at these things and looking at the vein thickness and measuring this can be helpful in a daily practice of the diagnosis. So in some ways, as Sri was saying about looking at the vessels in the eye, for example, this is looking at the femoral veins and measuring the aspects of this. And an early diagnosis is important, as we've said, and this may be another mechanism in which we can identify what's going on. And seeing what's happening in one vascular site that may be relevant to other vascular sites as well. The paper's been accepted, it will be published soon. We did a Delphi study along this point that Eslam was saying is what is a Behçet's ulcer. And to do this, we got a whole lot of pictures of Behçet's ulcers, ulcers from patients with IBD and other conditions, and also just patients with recurrent aphthous ulcers. We had an international panel of experts that look at this, and they were not oral medicine experts. They were people that actually diagnosed Behçet's in the clinic. And then you go through these rounds, your questions in round 2 are based on round 1 and so forth and so on. And what we've found is it showed a clear distinction between Behçet's from Behçet's disease patients or from IBD and some other ones from a disease called mucous membrane pemphigoid, which isn't really similar to Behçet's in some ways, but they do get the mouth ulcers. The one thing, of course, that would make life a lot different, it was more difficult to distinguish between standard recurrent aphthous ulcers and Behçet's. But the clinical descriptors that have defined Behçet's ulcers have been agreed. And this is them on this thing. So things like, Eslam has mentioned some of these, but the margin, the base, the shape, the color are all very strong indicators, all the way down to things such as location and size. So we think that this might be new clinical guidance that we can actually put out there to help people when you're just looking at mouth ulcers to say, right, this is potentially a thing. And again, this is all related to an increased and quicker diagnosis. Some other work that this Autoinflammatory Disease Alliance Network, there's a lot of papers coming out of Italy based on this. And they were looking at things like multiple regression, showed that the BD-QoL score could significantly predict global socioeconomic impact of BD. So this is a huge database that they've got, and they're investigating it in a whole series of others. And they found, for instance, that 56% of their patients had to pay out of their own pocket for medical examinations required to reach a diagnosis. This is in Italy, but has given us information about Behçet's that may be relevant in other circumstances. We've mentioned about treatment as well. And one of the things about the clustering that Deva mentioned is that this drug, secukinumab, which blocks anti-IL-17, is effective at dealing more with mucocutaneous disease, whereas anti-IL-6 is better in patients who are refractory to anti-TNF and ocular and neuro-Behçet's. So the clustering can also help us select patients to go into the trials that Rob, for instance, is doing with secukinumab, and therefore get a better outcome in terms of that. Just about IL-17, we also have to be a little bit careful. This molecule here on the right, the SLAM6 cells, that's your classic Th17 cell that go out in the circulation, what would be involved in damage. But there's also this one, this sort of pink cell across there, linked to the microbiome, and that actually protects the gut in various ways. So we have to be a little bit careful about what we take out as far as that's concerned. But secukinumab has been used in many, many patients, not just Behçet's disease, and it's generally, safe as far as that's concerned. If anybody wants some bedtime reading, then Amir Sarwala and Ahania Devesh-Kennelly put together this a series of essays and papers that are out there on Behçet's disease from bench to bedside. We've got one in there about the microbiome, for example, but there's a lot of very good publications in there if you wish to do so. I'll just mention Anna, who did all the work as part of her PhD with the aphthous ulcers and things like Fight for Sight and the MRC, who funded bits of this work. Now, this has actually been a look forward in terms of what we think that might become useful and what we can do. I'll also just have a look back. We came across a photo album in the department that goes back a long way. So here's Professor Moots as a fresh-faced young lad, sort of, doing his best out there to do what happens. There was also one of me. Can't see any difference, so probably the same shot, actually. But the one that probably showed perhaps the biggest difference and change in terms of that was the one doctor said, So, obviously going for the facial hair look and doing very well on that. So I will leave it at that.
Okay, so we're going to break now for a little bit, just for some coffee, I think. Don't forget that you have feedback forms on your tables, and we'd encourage everybody to fill that in. If you're watching online, there is the link to the feedback form in the chat, but also you'll be taken to that after the webinar as well. So for those in the room, are we still saying 5-2? 5-2, so that we can start for 3. It's the same for those online. All right, so grab a coffee.